I will reintroduce Drs. Allison-Bryan and Huntoon, again, who are going to speak on opioids. I'm also going to introduce Dr. Debbie Melnick from our BCSQI SAN 2.0 grant program. Debbie is going to help facilitate discussion of our next steps as a group regarding opioids, regarding maybe patient safety in general, after we hear from these two. So, Barbara, can I hand it over to you?
You want to bring up my slides? I'll let you do that first. I have a pretty loud voice, so I think we're probably going to be okay. So just a little word, I am the first act. I'm the part you didn't pay for because you really wanted to hear the headliner who is coming on after I do. You're probably going to know, where's the full slide? That's it. There you go. So probably you're going to know 90% of what I say, but it's just kind of interesting to maybe hear where these regulations came from. And as anyone would tell you, when you're talking, you tell them what you want them to know, then you tell them and then you tell them again. If from what I say, you only hear one thing, it's that the regulations don't really say don't do this. They don't say not. They don't say you're not allowed to do this. They don't say you can't do this. They are incredibly liberal, even though you don't believe that right now. And it's I'm going to walk you through some of them so that you just see that what the regulations ask us all to do is really practice good medicine, just like we teach interns and residents. Just practice good medicine. If you do it, write it down. And we certainly don't want to be culpable in what's going on right now. We don't want to be part of the problem. So thank you very much. And we are part of the problem. As Dr. Spears alluded to, you're seeing a big jump in the endocarditis, and that's because in the 1960s, 80% of the people who became addicted to opioids started with heroin. That's the way it was. By the 1990s, 80% of people who became addicted to opioids were starting with a prescription drug. So something changed in those 30 years. And right now, in this country, with 5% of the world's population, we are using 80% of the world's opioids. I honestly don't believe we have 80% of the world's pain. There is something really wrong. There is a mismatch. And I am a pediatrician. 11% of high school seniors report that they have used a prescription opioid that wasn't prescribed for them, that wasn't theirs, that was in the house, that they bought, that they got. And there is just something wrong with that. I'm sitting with a bunch of cardiologists and cardiac surgeons, but you lost this one. You are not the leading cause of death in people between 25 and 45. So no matter how much you wanted to hang on to the stat, we don't have it anymore because drug overdose is the leading cause of death in that age group. This is just a prettier slide that I have to attribute to behavioral health and disabilities, not the Department of Health Professions, but it just says about the same thing that we said. There is a huge problem. 1 in 6 high schoolers have misused prescription drugs. Every 12 hours, someone dies from an opioid overdose. Over 4,000 emergency administrations of Narcan. 1 in 56 high schoolers have used heroin. Every 2 hours, someone's arrested. And we're spending too much money on this problem. What's the answer? Like anything, it's got to be multifactorial. There's no question. I am not going to stand up here and tell you that regulations are the panacea and they're going to solve everything. But they may be part of the problem, part of the solution to this big problem. I hope they're not part of the problem. I was on the Board of Medicine in 2017. In fact, I was on the Board of Medicine last month at this time. And in 2017, some of the representatives from Southwest Virginia became very anxious about what was happening in their areas with the amount of drug overdose, both with opioids and with buprenorphine. And they set out to mandate legislation that would curb this. And they wanted to put what we now have as regulations in code. And that was scary to those of us on the Board of Medicine because they, for the most part, are lawyers and they don't practice medicine. And it is the job of physicians to regulate themselves. That's what the Department of Health Professions is. We are here to regulate and to monitor ourselves. And so at that point, we had very, very little time to act. And I will tell you that on January the 6th of last year, a regulatory advisory panel met at the Department of Health Professions that was composed of about 8 people with a whole lot more subject matter expertise than I had, though I sat in the middle of the room. And I was the filter that all these people went through, and that is where the draft regulations were crafted. I remember sitting there saying, if we don't leave here with a product, it will be done to us. We need to do this. And so it was that day on January 6th that we formulated the regulations. We used the CDC guidelines. They were a good Bible to go by, to pull things out of. It's awful to look at a blank computer screen. You just can't do it. And you say, well, I'm going to solve the opioid problem. Here's how I'm going to do it. But the CDC had done a lot of legwork. Very, very interestingly, the Board of Medicine of the Commonwealth of Virginia, 10 years ago, submitted regulations for the use of opioid medication for acute pain to the governor, who was, by the way, a Democrat at that point, and they were not signed. They were not signed. He would not go, did not see the need to do it. 10 years ago, the Board of Medicine. And so at that regulatory advisory panel, I had 10 years ago regulations, and they weren't bad. They really weren't half bad. So we had some things to work with. Emergency regulations were promulgated that day, and they were signed 1 year ago today by Governor McAuliffe. This is the birthday of the emergency regulations. Permanent regulations, just the way the code is written, permanent regulations are required within 18 months. The Board of Medicine has worked on those. They are on the governor's desk, and obviously it's been 12 months, not 18. But they are not very different from the initial ones that came out. And I'll point out 2 of the major differences between the emergency regulations and the permanent ones tonight. There are 3 sections to the regulations, one dealing with acute pain, one dealing with chronic pain, and one dealing with the use of buprenorphine for medically assisted treatment. Remember, they don't say what you can't do. They say what you need to do. And so if we're going to treat acute pain, you need to take a history and physical. Well, yeah, I think that just makes sense. That's not asking you to do any of us to do anything that we shouldn't do. But our history, if we're going to treat pain or give opioids, must include some history of the patient's risk of substance abuse. That needs to be there. First thing you always want to do is consider the non-pharmacologic and non-opioid treatments prior to using opioids. We're talking now about acute pain, we'll be talking about post-surgical pain, but the latest data says that non-opioids for chronic pain, like back pain and osteoarthritis, are at least as good and maybe better than opioid medications. So please consider non-pharmacological and non-opioid treatments. If we need an opioid, if we need it, use a short-acting opioid in the lowest dose for the fewest possible days, not to exceed 7 days, unless you query the P&P. If you want to give 14 days of medication, just query the P&P. That's all you have to do. It does not say, I cannot write for more than 7 days of medicine. It just says, if you write for 7 days, more than 7 days of medicine, you must query the P&P. And here's one of the big changes. This is between the emergency regulations and the final regulations. The emergency regulations did not, and this was mandated by our General Assembly. This is not something that the Board of Medicine made up. The emergency regulations said that you did not have to query the P&P for post-surgical pain unless you were going to give more than 14 days. That 14-day exception is now gone. Okay, that's gone. And it might not officially be gone if it hasn't been signed yet, but it's going to be gone in the next 24 hours, so let's just assume it's gone. Because it's there. So new for 2018, the 7-day limit is also for post-surgical pain, and that's a significant change, especially to the docs in this room. If you need to give an opioid when someone is either on a benzo already, or you feel the need to give both a benzo and the opioid, you have to say why. And you have to say how you're going to taper one or the other or both of them. Because the risk of overdose, the risk of death, and the risk of side effects is just exponential when the two drugs are given at the same time. And a milligram morphine equivalent is what you have to think about, because that's how we think about how high the dose is. These numbers are extremely generous, and I'm going to leave it to Mark to say how generous they are. But if the initial dose, remember that the good medicine said lowest possible dose for the fewest number of days. That's all it says. It doesn't say you have to start with a Tylenol number 3. It doesn't say that. It just says the lowest possible dose for the fewest number of days. And the initial dose should not exceed 50 MMEs. And if it does exceed 50 MMEs, all you have to do is say why. Little note in the chart, why. And if you go over 120, you have to document why or consult with a pain management specialist. Again, it doesn't say you cannot use more than 120. It just says think before you leave. And there is a note that you should prescribe naloxone if you're going over 120, which is a huge amount of drug. It's a huge amount of drug. Or for anyone with a history of prior overdose, or if you're giving a benzo with it. So, and that will now be tracked by the PMP, by the way, too. This, I don't know if you can see this chart, but it just kind of shows you what 50 and 90 MMEs looks like. I mean, it's 10 tablets. That's a lot, you know. It's not a small amount of drug that's there. And if you have trouble with this, there are calculators all over the place. I mean, you can just put them in if you're not sure. So, chronic pain, I'm not sure how many people in the room are treating chronic pain. And these regulations look almost identical to the acute pain with 2 exceptions. The first exception is that you need to get a urine drug screening or a serum medication level prior to initiating the treatment for chronic pain. And when the initial regulations, the emergency regulations came out, this is a place where Virginia's regulations differed from the CDC recommendation, and Virginia put in there that urine drug screen had to be checked every 3 months. That is no longer the case. The emergency regulations do not require a urine drug screen every 3 months. The final regulations do not require a urine drug screen every 3 months. It's at least once a year or when needed. So that's a big, that loosened things up a little bit. But you must check the PMP first. There's no 7-day, I'm going to treat chronic pain for 7 days. You've got to check the PMP. Assess the risk of substance misuse, just like we've done before, and have a risk-benefit discussion, get informed consent, and a treatment agreement. And those are real, tangible things, and Mark will probably talk more about those. That you need to have some sort of a contract. Once again, consider the MME, document why it should exceed 50 MMEs prior to exceeding 120. Think about why you do it, write it in the chart or call Mark. You have naloxone if you're using over 120. And again, here's the caveat about co-prescribing benzos and sedative hypnotics with the opioids. It's not significantly different except for the urine check and the mandatory PMP check. Did I skip one? Every 3 months, you need to see them at least every 3 months to review the course of treatment, document a rationale, recheck the PMP, and there's that change in the urine screen as needed at least yearly. There are exemptions. Another change from the emergency regulations to the final is in addition to terminal cancer and palliative care, sickle cell disease has been added to the list of exemptions. And that is hot off the press change. So that is another exemption. And that means that it's exempt. You don't have to check the PMP, you don't have to do anything. You might want to anyway, but there it is. Everybody knows about the PMP, right? I don't have to do this, or don't be embarrassed. You got it? Okay. And that's how you get onto it. If you don't, I can let you know. Have we made a difference? You know, it is the birthday of the emergency regulations. In the past year, the number of individuals receiving a prescription for an opioid has dropped 30%. That's pretty impressive. That is pretty impressive. Now, some of that, I'm not kidding myself, some of that is because even though I'm standing up here saying that the regulations don't say don't do this or don't say no, there are a lot of physicians who have said, I'm not doing this anymore, and they've said no. So the number of prescriptions has fallen, maybe not for good reasons. The number of doses of opioids prescribed has decreased 40% since the increase, since the regs. And so that's got to be important. But here's the part that's hard, and it's the part that Dr. Spears alluded to. The number of deaths from opioid overdose is continuing to go up. And that is because when you can't get it by prescription, you're going to get it on the street. So when I accepted this invitation to talk, Eddie told me that I didn't know about the study and the work that Dr. Spears had talked about earlier, but Eddie told me that he kind of sent some surveys around and you all had interviewed one another and each other to see if there was any consensus in how you're treating acute and post-surgical pain, and the answer was there wasn't a lot of consensus. So what I've given you isn't going to give you a whole lot of information there, but at least if you know it doesn't say you can't do something, it leaves things wide open for you. I don't know if anybody in the room does medical assisted treatment. Buprenorphine is the major drug that is used. It comes as a mono product, and it comes hooked to naloxone. In order to prescribe, you have to have a waiver. It is the most commonly diverted drug in Southwest Virginia. It causes more problems and more hassles there than any other opioid. So the emergency regs and the final regs address the use of buprenorphine. It limits the use of the mono product to pregnancy, conversion from methadone, and it states that only 3% of your patients can be on the mono product. The mono product is obviously a lot more attractive because if it's hooked to naloxone, you don't get quite as much bang for your buck because you're taking the agonist of this.
Barbara, is that when you use it for pain too?
Yeah, when you use it for pain, it can be used, it certainly can be used for, the mono product can be used for the treatment of acute pain. That's the question.
Chronic pain?
I think it's just acute, but I can check.
I actually disagree with that.
Yeah, so it might be. So this is a slide that, since we're talking about have the regulations made a difference, the blue line on the slide is data from the Virginia State Police on the number of doses of mono product that have been seized, and it peaked in 2016 and was markedly down last year. And at the same time, the bars are data from the PMP, the green part showing the proportion that is Suboxone or the buprenorphine naloxone, and the yellow bar showing the mono product, and you can see that the amount of mono product that's being written is down as well. So there probably this is making a difference, that there's less Subutex on the street, which is a good thing. And if you want to know me, that's who I am, but I'll be sitting right over here.